genetic disorder, impaired mucociliary clearance with chronic mucostasis and recurrent airway infection. Improved therapy has increased survival into adulthood. Before, it was known that the prognosis is bad, but now the improvement of the treatment tools improved the survival. The characteristic high-resolution CT features, they are predominantly involving upper lobes. And there is central bronchiectasis, 3-in-bud opacity, and mucus plugging. Upper lobar involvement with bronchiectasis and 3-in-bud. As you can see here, it's less involvement in lower lobes than upper lobes. Here are tiny 3-in-bud and nodules. We will see another examples of the mucoid impaction or mucus plugging. As you can see here, the distal portion of the dilated bronchus is obliterated. So this is the mucus plugging. This is the bronchocele. Again, here also, these are bronchocele. Beside the presence of the bronchiectasis, they are centrally located. Here, an example of female 25-year-old cystic fibrosis, central bronchiectasis in upper lobes, starting from the hila, predominantly upper lobar. There is sign of activity in lingula with consolidation, much less involvement in lower lobes. So that's why it is upper lobar predilection. Let me play the video again by myself. See the bronchiectasis. This is the mucus plugging. And the bronchiectasis, mucus plugging here. See, here we have consolidation. So this is activity, cystic fibrosis, and he's encountering an active episode now, consolidation. So this is sign of activity in a case of cystic fibrosis, and also here in the lingula, which is consolidation collapse with bronchiectasis air bronchogram. 3-in-bud and mucus plugging seen also in the same case. This is an image showing the bronchiectasis, bronchiectasis, continuity of the bronchiectasis starting from the central region, and this is mucus plugging. Here we have the 3-in-bud. In the mosaic attenuation session, we will talk about the mosaic attenuation, and we will mention the reason of mosaic attenuation in cases of bronchiolitis. But at least here we know this is mosaic attenuation that can occur in cases of bronchiolitis due to obliteration of the bronchioles. So it will cause regional mosaic attenuation, low attenuation of the lung parenchyma in a lobular appearance. So this is the appearance in case of airway disease causing mosaic attenuation, because in vascular cause, it will be non-lobular and geographic. So this is the 3-in-bud in this region, and here also there is bronchiectasis. Here is a cavity. It can be due to superimposed tuberculosis. What else? A raised hand from Dr. Nikos. Okay, let me see your question. When should we be using the term bronchiectasis versus inflammatory bronchial dilatation? Bronchiectasis usually implies non-reversed. Yes, great. That's why we should use the term bronchiectasis with caution, because Let me show you an example. This is bronchiectasis. This is not bronchial wall thickening because here there is loss of tapering. This is distortion of the bronchi. The peribronchial thickening will not affect that the bronchus is tapering to the distal portion of the lung. And with treatment, it can be reversible. So we should reserve bronchiectasis to the condition that they are irreversible, but not to spoil the use of bronchiectasis for cases of bronchial dilatation and bronchial wall thickening. If they are tapering, so they are reversible by treatment. But here they are showing that they are expanding and there is no tapering. See, this is bronchiectasis. There was a question. So it's loss of tapering. Yes, this is the only, in my opinion, the only sign for sure bronchiectasis, because signet ring has pitfalls. Signet ring doesn't mean there is true bronchiectasis. Don't use the tram track sign or the signet ring sign. They are originally established in X-rays. It was helpful there. But in CT scan, you can see the course of each bronchus and assess if they are tapering or not. Good question, Dr. Nikos. So we have here tree bud, bronchiectasis, and mucus plugging. Here, mucus plugging. This is not consolidation. And in an image, let me see the previous case. Maybe I can see the mucus plugging better to explain this. See, this is bronchiectasis. In this example, yes. See, the bronchus, here it's patent. Then it is opacified. It is now mucus plugged. See the continuity of it. So this is started to be showing some air in the tubular structure, which is blocked here, obliterated here by the mucus. These are mucus plugging. Where else you can see mucus plugging? Here, partially thickened. Peribronchial thickening will not be eccentric. So this is partial mucus plugging of this air bronchogram. See, this chronicity causes distortion even in the course and displacement of the bronchi. In this case, how can we tell between consolidation around the airway and activity? There is activity because of the consolidation. Dr. Nikos, here it's this is obvious. Consolidation with air bronchogram. This is another consolidation with air bronchogram and ground glass opacity. So this is activity of this cystic fibrosis case. Okay. Go for the sure sign. But why it's not cicatricial atelectasis? We'll talk about cicatricial atelectasis. It will be associated with loss of volume. Here, there is no loss. There is no loss of volume. And also there is cavitation, another sign. Here we have a cavity. This is another sign of activity of this patient. There are cavities indicating another superimposed infection causing this, and most likely it is tuberculosis here. The important thing in cicatricial consolidation is the presence of loss of volume. It will cause cicatricial atelectasis from its name, will cause atelectasis and loss of volume. Here we cannot encounter or appreciate presence of loss of volume. Let's proceed to the next. At least we want to alarm, not only to mention that there is traction, traction bronchiectasis is retain also traction to the fibrosis. But in infection, it is bronchiectasis. Don't put traction in front before the word bronchiectasis. It's bronchiectasis only. If you want to add something to discriminate, add infectious bronchiectasis. So we have not only to be descriptive, there is bronchiectasis, but a mucus plugging. So we should alarm that there is a possibility of underlying systemic condition, cystic fibrosis, if in upper lobes. If it is not known clinically or mentioned in the request. There is another case. We saw this case already. Let's proceed. I saw this image. Okay. There is another thing helpful for you to diagnose cystic fibrosis. It is upper lobar involvement, the triad, central bronchiectasis, tree bud, and mucus plugging. And usually this patient has also involvement of the sinuses. There is chronic sinonasal disease. Because of the age of patient, usually and they are mentioning it in literature that frontal and sphenoidal sinuses often underdeveloped. However, in this case, underdeveloped. But what is more important, that patient showing chronicity of chronic sinusitis, of involvement of sinusitis. There is osseous thickening and obliteration of the maxillary sinuses here. So this is chronic sinusitis in the patient of cystic fibrosis. Again, there is thickening of the walls of the boundaries of maxillary sinus. Another clue or another question for Dr. Marwa, asking what percentage you mean? Can you clarify more your question? Okay. Here, another thing characteristic for patients of cystic fibrosis, that patient, never mind, Dr. Marwa, never mind. Here in patient of cystic fibrosis, you can see in the image, in the upper abdominal cuts, manifestations of involvement of pancreas. They are ranging from recurrent pancreatitis causing calcification within the pancreas to complete fat replacement. Here in this case, we see diffuse pancreatic punctate calcification in the upper abdominal cuts after you see the upper lobar involvement of the triad. Another example of the chronicity of pancreatic involvement will cause cystic changes within the pancreas or fat replacement of the pancreas, and you cannot see the pancreas here in front of the splenic vein because of cystic fibrosis, chronic pancreatic involvement. Also, because of the bronchiectasis and cavitary lesions that can be occurring in cases of cystic fibrosis, patients can be complicated by pneumothorax and even recurrent pneumothorax. He's an example of 19-year-old patient with cystic fibrosis showing pneumothorax. I'm not asking to diagnose the patient for this in this phase, but at least to suggest it in this phase. Here, an example of 9-year-old female in image A, and it was the baseline image. And in B, after 1 year, sorry, 10-year follow-up, see the condition, how it develops, tree bud bronchiectasis, and they are central, 3 bud. There is consolidation here. Here, just peribronchial thickening. Peribronchial thickening, one of the features in radiology that are neglected or not given weight in reporting. Peribronchial thickening was present in the patient when he was in 9-year-old. At least mention peribronchial thickening, looking for small airway, centered airway disease. So patient will not normal. If you mention this case normal, it will pass normal. But if you mention there is small airway centered disease possibility due to peribronchial thickening, here this will alarm pulmonologists to consider the differentials. Here another example for 1-year-old female in image C, and it was the baseline, not showing the bronchiectasis seen after 10 years follow-up. And this is the consolidation that alarm for activity. Patient here was going on and off for repeated recurrent infections in upper lobes, specifically with ground glass opacities and reticulations or parenchymal bands involving the upper lobes. This passed unnoticed to alarm cystic fibrosis. At least not to miss to diagnose cystic fibrosis in this stage radiologically. The second entity to involve the upper lobes is the allergic bronchopulmonary aspergillosis. It is hypersensitivity reaction